The glass doors of Mercy Hill Medical Center glided open, letting in a gust of winter air and a swirl of tension that seemed to pulse through the modern lobby. Inside, nurses buzzed from station to station, visitors gathered in small knots, and patients waited quietly, shuffling through insurance cards and appointment slips. A black woman with an air of quiet strength stood near the reception counter. Her navy blue suit was perfectly tailored, her shoes polished, her expression composed. Denise Taylor's salt and pepper curls framed a face that radiated confidence and patience. In her hand, a worn leather briefcase, well cared for, clearly used for far more than doctor visits. The receptionist, Marissa Johnson, offered a polite smile as she sifted through a stack of paperwork. "Thank you for your patience, Ms. Taylor. I just need to scan your insurance card, and you'll be all set for your appointment." Denise's answer was warm but measured. "No rush. I know mornings can be busy." Across the room, two nurses whispered as they watched Dr. Ryan Porter approach. He cut a striking figure in his pristine white coat, his movements purposeful. Ryan was the type who seemed to own every room he entered, a reputation built over years of demanding work and, some said, an intolerance for mistakes. He glanced toward the reception desk and then at Denise, eyebrows knitting as if he'd spotted something out of place. He leaned in, addressing Marissa just loud enough for others to hear. "Do we have a new patient this morning?" Marissa nodded, lowering her voice. "Ms. Taylor has a checkup scheduled with Dr. Bennett. Her paperwork's all here." Ryan looked over Denise with a flicker of skepticism, then shifted his attention back to Marissa. "I don't remember authorizing a new intake for today. Next time, make sure the administration approves any outside referrals, please." Marissa, caught off guard, tried to explain. "She was referred online, Doctor Porter. It's all in the system." He waved her off. "Just make sure it doesn't happen again." Denise pretended not to notice, but there was a subtle tightening at the corners of her mouth. She quietly accepted her paperwork back from Marissa, then took a seat near a bank of windows. Outside, snowflakes drifted by, settling on the ledge. Not far away, a young man in hospital scrubs set up his phone for a morning live stream. His following had grown steadily, including med school followers, aspiring doctors, and patients curious about life behind the scenes. He pointed his camera toward the entrance, narrating softly as the hospital woke up for the day. The nurse called Denise's name, and she rose with easy poise, following through a maze of hallways into exam room 4. The nurse took her vitals, blood pressure, temperature, and pulse, working quickly but with obvious respect. "Everything looks good, Ms. Taylor. I'll let Dr. Bennett know you're ready," she said, smiling before stepping out. Denise waited. She scrolled through her phone, responded to a few messages, and gazed out at the abstract painting on the far wall. Her patience seemed infinite. Minutes ticked by. No one arrived. In the nurses' station just outside, Dr. Porter scanned the appointment list, irritation flickering on his face. "Why is Ms. Taylor still in exam 4? He demanded. A nurse explained. "She's scheduled for a new patient checkup with Dr. Bennett. The referral is in her chart. Everything's fine." He glanced at the chart himself. "South Shore Clinic, not part of our network. Did anyone confirm insurance?" "She provided it at check-in," the nurse replied, not missing a beat. Ryan's jaw tightened. "I'll handle this." He entered the exam room with a brisk knock, barely waiting for a reply before opening the door. Denise looked up, calm and unruffled. "Good morning, doctor," he replied with clipped formality. "I'm Dr. Porter. Dr. Bennett isn't available right now. I'll be reviewing your file." He shuffled through the papers, clearly looking for a reason to delay or dismiss. "You're a new patient?" he asked, as if the answer would change anything. "That's correct," Denise answered. "I'm not seeing the proper referral. South Shore isn't in our main network." She handed him a printed form. It was faxed last week. Dr. Lewis referred me. He barely glanced at it. Insurance? Already provided, she said, voice steady. His tone cooled further. We don't normally accept new patients without in-network referrals. You'll need to reschedule or try a different clinic. Denise remained composed. I have an appointment, and I've already completed my lab work. He stiffened. Our schedule is for established patients. I'm not comfortable seeing you today. Please follow up with your primary care doctor. She looked him in the eye. So you're refusing to treat me? He shifted, uncomfortable. You will need to leave, ma'am. I have other patients to see. Denise let a moment pass, her voice still calm. I'd like to speak with your supervisor. Ryan's lips curled in a tight, dismissive smile. You're looking at him. I'm the supervising physician for this department. The door closed behind him with a muted thud. In the waiting room, Marissa noticed Denise returning, a composed but purposeful set to her shoulders. Is something wrong, Ms. Taylor? Marissa asked quietly. Denise nodded. Could you please connect me to the hospital administrator's office? Marissa picked up the phone and dialed. Nearby, the med student's phone kept streaming. Comments were coming in rapid fire. She's being refused care. Someone call HR. Is this really happening? Viewers watched and the mood in the lobby shifted, curiosity giving way to discomfort, some pulling out their own phones to record. Denise sat patiently in the administrator's waiting area. Stephen Baker, the hospital administrator, came out to greet her, his smile practiced and polite. He listened carefully as Denise recounted her experience. I'm very sorry you felt unwelcome, Ms. Taylor, Baker offered. That isn't the kind of patient care we stand for here. Denise responded evenly. Thank you. I'd like to review your written policy on patient refusal, please. Baker hesitated. Of course. I'll have someone from compliance bring you the information. She continued. I'd also like to meet with your chief executive and board chair today, if possible. He blinked, caught off guard by the request. That's highly unusual, Miss Taylor. May I ask why? Denise reached into her briefcase and handed him a business card. His eyes widened as he read the title beneath her name. His entire demeanor changed. Absolutely, Mrs. Taylor. I'll arrange it right away. Word spread through the hospital corridors faster than any official memo could. Staff whispered in break rooms and at nurses' stations. That patient Dr. Porter tried to send away. They say she's someone powerful, a nurse murmured. Board level, apparently, another replied, scrolling through social media on her phone, watching clips from the live stream that were already circulating. In the staff room, Dr. Porter sat alone, his usual composure rattled. An email from HR appeared on his phone. Please report to the board conference room. He stared at the message, uncertain. The board conference room was already filled when he arrived. The hospital's top leadership, legal counsel, and board members were assembled, their faces grave. Denise Taylor entered, head held high, taking a seat at the head of the polished table. Chairman William Edwards spoke with a gravity that left no doubt. Dr. Porter, I'd like to introduce you to Mrs. Denise Taylor. She's not just a patient here. She's president of Mercy Hill's Board of Directors. Every head in the room turned. Dr. Porter's composure evaporated. He barely managed a nod as Denise looked directly at him. Thank you, Mr. Edwards, she said smoothly. I believe we have some urgent matters to discuss. The hush in the boardroom was absolute, a tension almost physical, as Denise Taylor addressed the table. She sat with an upright confidence that left no doubt about her authority, yet her tone carried none of the arrogance that sometimes clings to power. Instead, there was a steadiness, a determination shaped by experience. Thank you, Mr. Edwards, Denise began. her voice carrying easily to every corner of the polished room. Today, I'm speaking to you as both a patient and the president of this board. What happened to me this morning isn't just my concern. It's about what happens, unseen, to too many people who walk through these doors. Eyes darted to Dr. Porter, whose confidence had evaporated. He tried to steady himself, but the lines of defensiveness were already showing on his face. Denise leaned forward, hands clasped. I came in for a standard checkup. My paperwork was complete. My insurance was on file. And still I was questioned, redirected, and ultimately denied care, not because of any missing information, but because someone made a decision about who I am and where I belong. The legal counsel, Karen Foster, looked up from her notepad. Would you like to file a formal complaint, Mrs. Taylor? Denise didn't hesitate. Yes, but I also want a formal review. This wasn't a policy error, it was a judgment. And that has consequences not just for me, but for every patient who's ever been made to feel unwelcome. At the far end of the table, Dr. Porter finally spoke, his voice brittle. My intent was never to discriminate. I followed the intake policy for new patients. The system. She interrupted softly. Your intent may not have been discriminatory, but the impact certainly was. The policy isn't a shield for bad judgment. A subtle nod passed between some board members. Relief, perhaps, that someone was finally naming what many had only whispered about. William Edwards, the board chair, kept his expression neutral but attentive. Mrs. Taylor, your experience is troubling. Is this an isolated incident, or have you heard about similar cases? I've heard the stories, Denise answered. I've listened to complaints from community members who felt they were treated as if they didn't belong, questioned for reasons that had nothing to do with their health or their paperwork. If the president of the board can be dismissed, what happens to those with no title, no authority, just a need for care? Across the table, Amanda Riley, the hospital's communications director, scribbled notes. She could feel her phone buzzing with notifications, social media posts, news alerts, and messages from concerned staff. Her mind raced, already drafting a response, already calculating the fallout. Karen Foster's pen tapped the table. I recommend an immediate review of all patient intake procedures as well as comprehensive bias training for every employee. We need to be able to assure our community this won't happen again. William Edwards nodded. Agreed. And the review should include an audit of all patient refusals from the past year. We need to know if this is systemic. Dr. Samuel Green, another board member, spoke for the first time. If our own board president can be refused care, we have failed at the most basic level. We're here to serve everyone. The room fell silent as the weight of the situation settled over them. Dr. Porter shifted uncomfortably in his chair, finally understanding that this wasn't just about one morning's interaction. It was about the culture they had allowed to take root. Denise observed the faces around the table, reading the mixture of concern, embarrassment, and genuine resolve. She had seen this before in other institutions, other boardrooms where crisis had forced a moment of truth. The question was whether the commitment to change would outlast the immediate discomfort. I want to be clear, she continued. This isn't about punishment. It's about accountability. Every one of us in this room has a responsibility to ensure that what happened to me doesn't happen to anyone else. But that means we have to be willing to look honestly at our practices, our assumptions, and yes, our biases. Karen Foster cleared her throat. What specific changes are you proposing, Mrs. Taylor? Denise had anticipated this question. She reached into her briefcase and pulled out a folder. I've prepared a preliminary action plan. It includes mandatory bias training for all staff, a review of our patient intake procedures, the establishment of an anonymous reporting system, and regular community forums where patients can share their experiences directly with leadership. She handed copies around the table. I'm also recommending we bring in an external auditor to review our patient refusal data and identify any patterns we might have missed. Amanda Riley looked up from her notes. What about the media attention? This story is already spreading on social media. Denise met her gaze steadily. The best response to media attention is transparency and action. We acknowledge what happened, we take responsibility, and we demonstrate our commitment to change through concrete steps. Dr. Porter, who had been silent for several minutes, finally spoke again. Mrs. Taylor, I want to apologize. Not just for this morning, but for any time my actions may have made a patient feel unwelcome. I realize now that following policy isn't enough if the result is that people are treated unfairly. The room was quiet as his words hung in the air. Denise studied his face, looking for sincerity beyond the obvious fear of professional consequences. Thank you, Dr. Porter, she said finally. Apologies matter, but actions matter more. I hope you'll be part of the solution moving forward. William Edwards looked around the table. I think we're all in agreement that immediate action is necessary. Mrs. Taylor, how quickly can we implement these changes? The bias training can begin within the week, Denise replied. The intake procedure review should be completed within 30 days. The anonymous reporting system can be operational by the end of the month. She paused, her expression serious. But I want to emphasize that these are just the beginning steps. Real culture change takes time, patience, and constant vigilance. We can't just implement these measures and declare victory. We have to commit to ongoing assessment and improvement. Dr. Samuel Green nodded. What about community engagement? How do we rebuild trust with the patients who may have been affected by these issues? That's where the community forums come in, Denise explained. We need to create safe spaces where patients can share their experiences without fear of retaliation. We need to listen, learn, and respond with concrete improvements. The meeting continued for another hour with detailed discussions about implementation timelines, budget considerations, and communication strategies. As the formal session concluded, several board members approached Denise privately to offer their support and share their own concerns about issues they had noticed but hadn't known how to address. Dr. Porter lingered as the room emptied. Mrs. Taylor, he said quietly, I know my apology doesn't undo what happened, but I want you to know that I've learned something important today. I'd like to be part of the training program, not just as a participant, but as someone who can help others understand how easy it is to let bias influence our decisions. Denise regarded him thoughtfully. That takes courage, Dr. Porter. I appreciate your willingness to be vulnerable in the service of something bigger than yourself. As they walked out of the boardroom together, Denise reflected on the morning's events. The confrontation had been painful, but it had also created an opportunity, a chance to address problems that had been festering beneath the surface for too long. The real work, she knew, was just beginning. A sense of movement rippled through the hospital. Staff in break rooms and corridors whispered about what had happened. Nurses compared notes, recalling patients who'd faced extra scrutiny for having out-of-state IDs, different accents, or for simply not fitting someone's expectation of a typical patient. Word of Denise's experience traveled fast, far faster than any internal memo could. In the pediatric ward, Dr. Maria Santos finished her rounds and joined a group of nurses who were discussing the morning's events. As one of the few Latina physicians at Mercy Hill, she had her own stories of being questioned about her credentials, of patients asking to see the real doctor when she introduced herself. "I've been waiting for someone to say what we all know," she said quietly to the group. "It's not just about patients. Some of us have felt it too, the assumptions, the subtle questions about whether we belong." Nurse Jennifer Park nodded. "I remember when I first started here, a patient's family member asked me if I spoke English clearly enough to understand medication instructions. I laughed it off, but it hurt." In the hospital's main break room, the conversation was more heated. Some staff members expressed frustration with what they saw as an overreaction. "She got the same treatment any new patient would get," one technician argued. "Dr. Porter was just following protocol." But others pushed back. "Come on, Mike," said Rosa Martinez, a registration clerk. "You've seen how some patients get treated differently. I've watched people get questioned about their insurance when their paperwork is perfectly fine, just because they don't look like what someone expects." The debate continued throughout the day, spilling into elevators, meal periods, and shift changes. For many staff members, it was the first time they had openly discussed the subtle, and sometimes not so subtle, ways that bias influenced their workplace. Meanwhile, in the hospital's executive suite, Amanda Riley was fielding calls from local media outlets. The live stream from the medical student had generated significant online attention, with hashtags like #Mercy Hill Bias and #Patient Dignity trending on social media. "We need to get ahead of this," she told Denise during an emergency meeting. "The story is already being picked up by news stations. We should prepare a statement." Denise nodded. "But let's make sure it's not just crisis management. This is an opportunity to demonstrate real leadership." Together, they crafted a statement that acknowledged the incident, accepted responsibility, and outlined concrete steps for improvement. But Denise insisted on something more: a commitment to ongoing transparency and community engagement. "We're not just going to issue a statement and hope this goes away," she told Amanda. "We're going to use this as a catalyst for the changes we should have made years ago." By afternoon, the hospital's phone lines were busy with calls from community members, former patients, and other healthcare institutions. Some calls were critical, demanding accountability. Others were supportive, praising the hospital's willingness to address the issue head-on. One call that particularly moved Denise came from Mrs. Eleanor Washington, an elderly woman from the South Side who had been a patient at Mercy Hill for nearly 2 decades. "Mrs. Taylor," she said, her voice trembling with emotion, "I want to thank you for speaking up. I've been treated poorly at that hospital more times than I can count, but I never thought anyone would listen if I complained. Maybe things really will change now." Denise took careful notes during the call, adding Mrs. Washington's experiences of a growing file of patient stories that would inform the hospital's improvement efforts. As evening approached, Denise found herself in the hospital lobby, observing the flow of patients and families. She watched a young mother with her toddler navigate the check-in process, noting how the staff member's demeanor was perhaps a bit more welcoming than it might have been that morning. Near the information desk, she overheard a conversation between 2 elderly men waiting for their rides home. "You hear what happened here today?" one asked the other. "Something about a patient being turned away," the second man replied. "Turns out it was the board president. She was pretending to be a regular patient, and they treated her like she didn't belong." "About time someone saw what the rest of us deal with," the first man said. "Maybe things will change now." Denise didn't correct their misunderstanding about her pretending to be a patient. She was glad that the story was spreading, that people were talking about issues that had been ignored for too long. Later that evening, she met with William Edwards and Karen Foster to review the day's developments and plan for the immediate future. "The response has been overwhelming," Karen reported. "We've received dozens of calls from patients wanting to share their experiences, some positive, some negative, but all of them valuable. William looked tired but determined. How do we process all of this feedback constructively? We listen, Denise replied. Every call, every story, every complaint becomes part of our learning process. We can't fix what we don't acknowledge. They spent the next hour developing a plan for the community forums Denise had proposed. The first would be held within 2 weeks, with childcare provided and interpretation services available. The goal was to create a safe space where patients could share their experiences without fear of judgment or retaliation. As the meeting wound down, Denise felt a mixture of exhaustion and anticipation. The day had been difficult, but it had also been necessary. Change was never easy, but it was essential. This is just the beginning, she told her colleagues. The real work starts tomorrow. Outside the hospital, the news vans had arrived, their bright lights illuminating the parking lot. Reporters were preparing for the evening broadcasts, ready to tell the story of what had happened at Mercy Hill Medical Center. But inside the building, the most important conversations were happening in quiet corners, between colleagues who were finally talking honestly about bias, between supervisors and staff who were committing to do better, between patients and families who were beginning to believe that their voices mattered. The ripple effect had begun, and there was no turning back. The morning after Denise Taylor's confrontation, Mercy Hill Medical Center felt transformed. The energy in the halls was different, charged with anticipation, nervousness, and for some, a cautious hope. Staff exchanged glances in elevators, shared quiet conversations in staff lounges, and checked their phones for the latest updates. News coverage of the incident, amplified by social media, had turned the hospital into a focal point for the entire city. Dr. Porter arrived early, his usual confidence replaced by a heavy sense of uncertainty. He had barely slept, replaying the events of the previous day and grappling with the realization that his actions had exposed something much larger than a single mistake in judgment. In the physician's lounge, his colleague Dr. Ava Smith was reading the morning news on her tablet. She looked up as he entered, her expression sympathetic but serious. "Rough night?" she asked. Ryan poured himself a coffee with shaking hands. "Ava, I keep thinking about all the times I might have done something similar without even realizing it. What if this wasn't an isolated incident? What if I've been part of the problem all along?" Dr. Smith set down her tablet. "Ryan, I've known you for 8 years. You're a good doctor who cares about his patients. But yesterday, you let something else influence your medical judgment. The question is, what you do now." Their conversation was interrupted by Dr. Santos, who had heard about the incident through the hospital grapevine. "I'm glad you're having this conversation," she said, joining them. "As someone who's been on the receiving end of bias in healthcare, I can tell you that acknowledgement is the first step toward healing." She sat down, her expression earnest. "Ryan, I've watched you work. You're skilled and dedicated, but I've also seen you make assumptions about patients based on their appearance, their insurance, or their background. Yesterday wasn't an aberration, it was a pattern becoming visible." The words stung, but Ryan knew they were true. He thought about the number of times he had questioned a patient's symptoms more aggressively based on their appearance, or the occasions when he had assumed certain patients were drug-seeking without proper evaluation. "What do I do with that knowledge?" he asked. "How do I make sure it doesn't happen again?" Dr. Santos smiled gently. "You start by being honest about it. You participate in the training. You examine your own biases, and you become an advocate for change instead of an obstacle to it." Meanwhile, in the hospital's main auditorium, chairs were quickly filling up. Doctors, nurses, administrative staff, technicians, and nearly every department sent representatives, eager or anxious about what would be said. The meeting wasn't mandatory, but word had spread that Denise herself would be addressing the staff. Those who couldn't fit in the auditorium watched from break rooms and offices, eyes glued to streaming monitors. The crowd was diverse, long-time employees who had witnessed decades of changes, new graduates full of idealism, middle-aged professionals wondering if they were too set in their ways to adapt. Some came out of curiosity, others from a sense of obligation, and many from a genuine desire to be part of something better. Brenda Washington, the environmental services worker who had thanked Denise the previous day, sat in the front row. She had never attended a hospital-wide meeting before, but something about yesterday's events had given her the courage to speak up. Next to her sat Miguel Rodriguez, a security guard who had worked at Mercy Hill for 15 years and had his own stories about how different patients were treated. William Edwards stood at the podium and welcomed everyone, his voice steady. He didn't dwell on the controversy. Instead, he introduced Denise, describing her not just as president of the board, but as a leader who cared deeply for the hospital and everyone it served. Denise stepped up to the microphone, her expression calm but charged with resolve. She looked out at a sea of faces, some wary, some supportive, a few skeptical. The silence was complete as she prepared to speak. "Good morning," she began, her voice carrying clearly through the auditorium. "I know many of you have heard about what happened yesterday. I want to talk to you about it, not as the president of the board, but as a patient who experienced something that no one should have to endure." She paused, letting the weight of her words settle. "But I also want to talk to you about what it means to be part of a community that can either welcome or exclude, that can either heal or harm through the smallest of actions." A murmur rippled through the crowd. Some people shifted uncomfortably, others leaned forward with interest. "We all make judgments," she continued. "Sometimes we do it unconsciously. Sometimes we do it because we're tired or stressed or overwhelmed. But it is our responsibility, especially in a place like this, to see every person as deserving of dignity and care. Mercy Hill must be more than a hospital. It must be a home for healing, and that begins with every single interaction." She began to tell her story, not just about what happened to her as a patient, but about what it meant to be dismissed, questioned, and ultimately denied care. She spoke about the shame that patients feel when they're treated as if they don't belong, and the fear that prevents many from seeking the medical attention they need. "I have a title that gave me power yesterday," she said. "I could demand to speak to supervisors. I could insist on accountability. But what about the patients who don't have that power? What about the elderly man who doesn't speak English fluently? Or the young mother who's worried about her insurance? Or the teenager who's afraid to ask questions?" The auditorium was silent except for the occasional cough or whisper. Denise could see that her words were having an impact, that people were beginning to understand the broader implications of what had happened. "I'm not here to blame anyone," she continued. "I'm here to ask all of us to do better, to examine our own biases, to question our assumptions, and to commit to treating every patient with the same dignity and respect we would want for ourselves and our loved ones." She gestured to the crowd. "Look around this room. We represent every background, every ethnicity, and every economic level. We are the community we serve. And if we can't treat each other with respect, how can we expect to treat our patients properly?" A nurse in the third row raised her hand. "Mrs. Taylor, how do we know when we're being biased? Sometimes it's so subtle we don't even realize we're doing it." Denise smiled. "That's exactly the right question. That's why we need training, why we need to create systems that help us recognize our biases and correct them. It's not about perfection, it's about awareness and continuous improvement." Another hand went up, this time from a young resident. "What about when patients are difficult or demanding? How do we balance being respectful with maintaining appropriate boundaries? There's a difference between setting medical boundaries and making judgments based on bias, Denise replied. A patient's race, accent, insurance status, or appearance should never influence the quality of care they receive. But their medical needs, their behavior toward staff, and their compliance with treatment, those are legitimate medical considerations. For the next hour, Denise fielded questions, shared stories, and listened to concerns. Staff members talked about their own experiences with bias, both as providers and as patients. The conversation was sometimes uncomfortable, but it was necessary. Dr. Porter, who had been sitting quietly in the back, finally stood up. Mrs. Taylor, I want to publicly apologize for my actions yesterday. I want everyone here to know that I take full responsibility for what happened, and I commit to doing better. His voice wavered slightly. I also want to say that I've spent the last 24 hours thinking about other times when I might have let bias influence my decisions. I'm sure there were occasions when I questioned patients unnecessarily, when I made assumptions based on appearance rather than medical need. I want to be part of the solution, not the problem. The applause that followed was respectful rather than enthusiastic, but it was genuine. Denise nodded to Dr. Porter, acknowledging his courage in speaking publicly. As the meeting concluded, Denise stayed to listen. Staff approached her, quietly sharing their own experiences. One nurse recounted how she had once questioned a patient's insurance out of habit, only to discover it was a misunderstanding that left the patient feeling ashamed. A maintenance supervisor described watching colleagues ignore non-English speaking families, making them wait longer for help. A young doctor admitted in a near whisper that he had once assumed a black patient complaining of pain was exaggerating until he realized his error. Denise thanked each person for their honesty. She didn't judge or scold. Instead, she encouraged them to keep speaking up, to use their experiences as fuel for better care. For many, it was the first time they felt their voices were not just heard, but valued. Brenda Washington approached hesitantly as the crowd thinned. Mrs. Taylor, I wanted to thank you again. I've been here for 12 years, and I've seen things that made me uncomfortable, but I never knew how to speak up. What kinds of things? Denise asked gently. Brenda looked around to make sure they couldn't be overheard. I've seen patients get treated differently based on how they look or sound. I've watched families struggle to get information because staff assume they won't understand. I've seen people leave without getting the help they needed because they felt unwelcome. She paused, gathering courage. I've also seen wonderful care, don't get me wrong, but the bad moments, they stay with you. They make you wonder if you're the only one who notices. Denise placed a hand on Brenda's shoulder. You're not the only one, and your observations matter. Would you be willing to share your experiences with our review team? Brenda nodded eagerly. Yes, ma'am. I want to help make things better. As Denise finally left the auditorium, she felt a mixture of exhaustion and hope. The conversations had been difficult, but they had been necessary. Real change required honest acknowledgement of problems, and today she had seen the beginning of that process. The work ahead would be challenging, but for the first time in years, she felt optimistic about Mercy Hill's future. The hospital was ready to confront its uncomfortable truths and commit to becoming something better. Throughout the day, departments gathered in small groups to discuss new procedures. The legal and HR teams distributed drafts of new intake and patient interaction guidelines. These included clear language on bias, the importance of respect, and the expectation that all patients would be given equal consideration, regardless of background, accent, or appearance. Karen Foster led the first implementation meeting in the hospital's main conference room. Representatives from each department had been asked to attend, and the turnout was impressive. Nurses, doctors, technicians, administrative staff, and support personnel filled the room, their faces showing a mixture of curiosity and apprehension. "Today we begin the real work," Karen announced, her voice carrying the authority of someone who had spent years in healthcare compliance. "Yesterday was about acknowledging the problem. Today is about creating solutions." She distributed folders containing the new guidelines, each one carefully crafted to address specific scenarios that had been identified as problematic. The documents weren't just theoretical, they were based on real situations that had occurred at Mercy Hill and other hospitals. "These guidelines aren't about restricting your judgment," Karen explained. "They're about ensuring that your medical judgment isn't clouded by unconscious bias. Every patient deserves the same level of care, regardless of their appearance, insurance status, or background." Dr. Patricia Williams, the chief of internal medicine, raised her hand. "What about situations where language barriers make communication difficult? We sometimes need to verify insurance or medical history more thoroughly." "Excellent question," Karen replied. "The guidelines specifically address that. We're expanding our interpreter services and creating visual aids to help with communication. The goal is to remove barriers to care, not create new ones." She pulled up a presentation on the conference room screen. "Let me show you some specific examples of how these guidelines work in practice." The first scenario involved a patient presenting with chest pain whose insurance card had expired. The old approach might have involved extensive questioning about payment before providing care. The new approach required immediate medical assessment, while administrative staff worked in the background to resolve insurance issues. "The key principle," Karen explained, "is that medical need always takes precedence over administrative convenience. We treat first, we ask questions later." Rosa Martinez, the registration clerk, who had spoken up in the break room, raised her hand. "What about patients who don't have an ID or insurance? We used to have pretty strict policies about that." "We're revising those policies," Karen replied. "Emergency care is provided regardless of ability to pay. That's federal law. But we're also expanding our financial assistance programs and creating better processes for helping patients navigate insurance enrollment." The meeting continued for 2 hours with staff members sharing concerns, asking questions, and working through specific scenarios. By the end, there was a palpable sense of commitment in the room, not just to following new rules, but to embracing a new culture of care. As the formal meeting concluded, smaller groups formed naturally. Nurses huddled with doctors to discuss how the changes would affect their daily routines. Administrative staff worked with patient advocates to refine the new intake procedures. The energy was collaborative rather than defensive, a marked shift from the tension of the previous day. Dr. Santos approached Dr. Porter as he gathered his materials. "Ryan, I want you to know that I appreciate what you said yesterday. It takes courage to admit mistakes publicly." He looked up, his expression still carrying traces of the vulnerability he had shown in the boardroom. "Maria, I've been thinking about our conversation, about patterns I didn't want to see. I want to ask you something, and I need you to be honest with me." She nodded, encouraging him to continue. "Have you ever seen me treat patients differently based on their race or background? I need to know the truth, even if it's uncomfortable." Dr. Santos considered her words carefully. "Ryan, I've seen you be more skeptical of pain complaints from certain patients. I've watched you spend less time explaining procedures to families who don't speak English fluently. I've noticed you're quicker to assume drug-seeking behavior in some patients than others." The words hit him like a physical blow, but he didn't flinch. "How long have you noticed this?" "Years," she admitted, "but I didn't know how to address it without creating conflict. I told myself it wasn't my place to judge another doctor's decisions." Ryan was quiet for a long moment. I need to make this right, not just going forward, but for the patients I may have failed in the past. That's the hardest part, Dr. Santos said gently. We can't undo the past, but we can learn from it. The fact that you're willing to examine your own behavior honestly is the beginning of real change. 2 weeks later, the first community forum was held in the hospital's main auditorium. Denise had insisted on evening hours to accommodate working families, and the hospital provided childcare, interpretation services, and light refreshments. The turnout exceeded expectations. Over 200 community members filled the seats, with more watching via live stream. The audience was diverse. Elderly patients who had been coming to Mercy Hill for decades, young parents with toddlers, teenagers accompanying grandparents, and middle-aged professionals who had experienced the hospital's services. Some came with specific complaints, others with general concerns, and many simply wanted to see if the hospital was serious about change. Denise opened the forum with a brief welcome, then turned the microphone over to the community. Tonight is about listening, she said. We want to hear your experiences, your concerns, and your suggestions for how we can do better. The first speaker was Mrs. Eleanor Washington, the elderly woman who had called after hearing about Denise's experience. She walked slowly to the microphone, her cane tapping against the floor, but her voice was strong and clear. I've been coming to this hospital for 20 years, she began. I've had some wonderful doctors and nurses who treated me with kindness and respect. But I've also had experiences that left me feeling small and unwelcome. She described being questioned about her insurance multiple times during a single visit, being asked to repeat her symptoms to several different staff members who seemed skeptical of her pain levels, and being made to wait longer than other patients for reasons that were never explained. I always wondered if it was just in my head, she said. But when I heard about what happened to Mrs. Taylor, I realized it wasn't. The way you treat patients says something about who you think deserves care and who doesn't. The auditorium was quiet as Mrs. Washington returned to her seat. Several people nodded in recognition of her experiences. The next speaker was Carlos Mendoza, a construction worker who had been treated in the emergency room following a workplace accident. He spoke in accented English, occasionally pausing to find the right words. When I came here, I was bleeding from my arm, but they asked me about my immigration status before they asked about my injury. They made me feel like I was doing something wrong by needing help. He described waiting for hours while other patients with seemingly less serious injuries were seen first, and being discharged with minimal pain medication and instructions he didn't fully understand. I work hard, I pay taxes, I have insurance, he said, but I was treated like I didn't deserve to be here. That's not right. Amanda Riley, sitting in the front row, took careful notes. These weren't just isolated complaints. They were patterns that pointed to systemic problems in how the hospital approached patient care. A young mother named Jennifer Kim stepped up to the microphone next. She was well-dressed and articulate, but her story revealed that professional appearance didn't shield patients from bias. I brought my daughter here when she was having breathing problems, she said. The triage nurse asked me if I was sure it was an emergency, if maybe I was just being an overprotective parent. She suggested I might want to try a walk-in clinic instead. Jennifer's voice grew stronger as she continued. My daughter has asthma. I know the signs of a serious attack, but because I'm young and I look like a worried mom, my medical knowledge of my own child was dismissed. She described how her daughter's condition worsened while they waited, and how the dismissive attitude changed only when the child's breathing became visibly labored. My daughter received excellent care once they took her seriously, Jennifer said. But the initial response made me feel like I was wasting their time. No parent should have to prove their child is sick. The stories continued for nearly 2 hours. A teenager described being lectured about sexual health when he came in for a sports injury. An elderly man talked about being spoken to as if he were mentally impaired because he was hard of hearing. A middle-aged woman shared how she was questioned about her pain levels and made to feel like she was exaggerating her symptoms. But there were positive stories, too. Several patients praised specific doctors and nurses who had gone above and beyond to provide compassionate care. They described feeling heard, respected, and valued as human beings rather than just medical cases. Dr. Porter, who had been listening from the back of the auditorium, finally stood up. "I want to thank everyone who has shared their experiences tonight. As one of the doctors who has worked here for many years, I need to acknowledge that I've been part of the problem." He walked to the microphone, his voice steady but emotional. "I've made assumptions about patients based on their appearance, their insurance, or their background. I've questioned people's symptoms because of unconscious biases I didn't even realize I had. I want to publicly apologize to anyone who has been affected by my actions." The auditorium was silent as he continued. "But more importantly, I want to commit to doing better. I'm participating in bias training. I'm working with colleagues to examine our practices, and I'm committed to treating every patient with the dignity and respect they deserve." His words were met with respectful applause. For many in the audience, it was the first time they had heard a healthcare provider acknowledge the reality of their experiences. As the forum concluded, Denise invited attendees to continue the conversation in smaller groups. Tables were set up around the auditorium, each one focused on a different aspect of patient care: emergency services, outpatient care, billing and insurance, language services, and patient advocacy. The conversations at these tables were detailed and productive. Patients shared specific suggestions for improvement, while hospital staff took notes and asked clarifying questions. The atmosphere was collaborative rather than confrontational, with both sides working toward common goals. At the language services table, Carlos Mendoza described how confusing it was to receive discharge instructions in English when his injury made it difficult to concentrate. The hospital's patient advocate, Ava Smith, explained new plans for providing written instructions in multiple languages and ensuring that interpreters were available for all non-English speaking patients. At the emergency services table, Jennifer Kim worked with the triage supervisor to develop better protocols for taking parent concerns seriously while still maintaining appropriate medical judgment. They discussed ways to educate staff about the difference between anxious parents and parents who had legitimate medical concerns. The billing and insurance table was particularly active, with several patients sharing stories about being questioned about their ability to pay before receiving care. The hospital's financial counselor, David Martinez, explained new policies that would separate medical care from payment discussions, ensuring that financial concerns never delay necessary treatment. As the evening wound down, Denise felt a sense of accomplishment. The forum had provided valuable insights into patient experiences, but more importantly, it had begun to build bridges between the hospital and the community it served. "This is just the beginning," she announced as the formal program concluded. "We're committed to holding these forums quarterly, and we'll be implementing changes based on what we've learned tonight." She looked around the auditorium, seeing faces that showed cautious optimism mixed with lingering skepticism. Change takes time, but it starts with conversations like this. Thank you for trusting us with your stories. 6 months after the incident that shook Mercy Hill Medical Center, the changes were becoming visible throughout the hospital. The transformation hadn't been easy or immediate, but it was real and measurable. In the emergency department, new protocols had eliminated the practice of asking about insurance before providing medical care. Triage nurses now focused exclusively on medical need, while financial counselors work separately with patients to address billing concerns. The change had reduced wait times and improved patient satisfaction scores significantly. Dr. Porter had become an unexpected leader in the hospital's bias training program. His willingness to acknowledge his own mistakes and learn from them had made him an effective teacher for other staff members. He co-facilitated training sessions, sharing his experiences and helping colleagues recognize their own unconscious biases. The hardest part, he told a group of new residents during one training session, is admitting that your intentions don't matter if your impact is harmful. I always thought I was a good doctor who cared about all patients equally, but caring isn't enough if you don't examine your own assumptions. He clicked to the next slide in his presentation, showing statistics about health disparities in their community. These numbers represent real people with real consequences. Every time we let bias influence our medical decisions, we contribute to these disparities. A young resident raised her hand. Dr. Porter, how do you check yourself now? How do you know when you might be making biased decisions? I ask myself uncomfortable questions, he replied. Would I have the same level of skepticism about this patient's pain if they were a different race? Am I spending less time explaining this procedure because I'm making assumptions about the patient's education level? Am I rushing this appointment because of preconceived notions about this patient's importance? He paused, looking around the room, and I asked colleagues to hold me accountable. Dr. Santos and I have developed a system where we can call each other out if we notice problematic patterns. It's not always comfortable, but it's necessary. The training program had expanded beyond just the medical staff. Everyone from security guards to maintenance workers participated in sessions designed to help them recognize and address bias in their interactions with patients and families. Brenda Washington had become a powerful voice in these sessions, sharing her observations from years of working throughout the hospital. I see things other people don't notice, she told one group. I'm in patient rooms when families think no one important is listening. I hear the comments people make when they think it doesn't matter. She described watching a family struggle to understand discharge instructions because the nurse spoke too quickly and used medical jargon, then made no effort to confirm understanding. She talked about seeing security guards respond differently to disturbances depending on the race of the people involved. My job is to keep this place clean and safe, she said, but I've learned that safety isn't just about physical cleanliness. It's about making sure everyone who comes here feels like they belong. The anonymous reporting system had generated hundreds of reports in its first 6 months. Some were complaints about specific incidents, others were suggestions for improvement. Each report was reviewed by a committee that included both hospital staff and community representatives. One report had led to changes in the hospital's visitor policies. A patient had described how her elderly mother, who didn't speak English, had been made to feel unwelcome when she tried to visit. The report revealed that security guards had been asking for identification from certain visitors while allowing others to pass freely. The new policy required all visitors to check in, but it also provided interpretation services and simplified the process for non-English speaking families. More importantly, it established clear guidelines for how security staff should interact with all visitors regardless of their appearance or language. Dr. Santos had been promoted to Director of Patient Experience, a new position created to ensure that the hospital's commitment to equity was maintained at the highest levels. Her first major initiative was implementing patient navigators, staff members whose sole job was to help patients and families navigate the complex healthcare system. Healthcare is complicated enough when you're sick, she explained during a staff meeting. It shouldn't be more complicated because of your race, your language, or your insurance status. The Patient Navigator program had been particularly successful in the oncology department, where families often faced months of complex treatment. Maria Rodriguez, one of the first navigators, had helped dozens of families understand their treatment options, coordinate appointments, and access financial assistance programs. Before this program, I watched families struggle to understand what was happening to their loved ones, Maria said. Language barriers, insurance confusion, fear of the medical system, all of these things were getting in the way of care. Now we have people whose job is to remove those barriers. The community forums had continued on a quarterly basis, with each one drawing large crowds and generating valuable feedback. The hospital published reports after each forum, detailing what they had learned and what changes were being implemented in response. The most recent forum had focused on mental health services, with community members sharing experiences about seeking help for depression, anxiety, and other mental health concerns. The feedback had revealed significant gaps in the hospital's approach to mental health care, particularly for patients from different cultural backgrounds. We learned that we were applying Western models of mental health to patients from cultures that understand emotional well-being very differently, Denise explained during a board meeting. We're now working with community leaders to develop culturally appropriate approaches to mental health care. The hospital had also established partnerships with community organizations to address some of the root causes of health disparities. They were working with local schools to provide health education, partnering with community centers to offer free screenings, and collaborating with social service agencies to address issues like housing instability and food insecurity that affected patient health. Amanda Riley had documented the hospital's transformation in a series of case studies that were being shared with other healthcare institutions. The story of Mercy Hill's change had attracted national attention, with delegations from other hospitals visiting to learn about their approach. The key, Amanda explained to one visiting group, was that we didn't just change policies, we changed culture. We acknowledged that good intentions weren't enough if they didn't translate into equitable outcomes. She showed them statistics demonstrating the hospital's progress. Patient satisfaction scores had improved across all demographic groups, but the gap between different populations had narrowed significantly. Complaint rates had decreased, while compliment rates had increased. Staff turnover had declined, and employee satisfaction surveys showed higher levels of job satisfaction and pride in their workplace. But perhaps the most meaningful measure of success was the change in stories patients told about their experiences. The community forums now included more positive testimonials, with patients describing feeling heard, respected, and valued during their care. Mrs. Eleanor Washington had become a regular attendee at the forums, often sharing updates about her ongoing care. "I still see the same doctors I've always seen," she told the most recent gathering. "But the conversations are different now. They ask about my concerns, they explain things clearly, and they treat me like my opinion matters." She paused, looking around the room. That might not sound like much, but when you're sick and scared, feeling like you matter can be as important as the medicine. The transformation at Mercy Hill had begun to influence other institutions throughout the region. Dr. Santos received regular calls from colleagues at other hospitals, asking for advice on implementing similar changes. The bias training program had been adapted for use in medical schools, nursing programs, and healthcare systems across the country. "What we've learned," Dr. Santos explained during a national conference presentation, "is that systemic change requires more than individual awareness. It requires institutional commitment, community engagement, and ongoing accountability." She clicked through slides showing Mercy Hill's journey, from the initial incident to the comprehensive changes that had followed. "We didn't just want to avoid future discrimination complaints. We wanted to fundamentally change how we think about patient care, and what it means to serve our community. The conference audience, healthcare administrators, policymakers, and clinical staff from across the country listened intently as she described specific interventions and their outcomes. The story of Mercy Hill had become a case study in how healthcare institutions could address bias and improve equity. Back at Mercy Hill, the work continued. The hospital had established a permanent equity and inclusion committee with representatives from every department and several community members. The committee met monthly to review progress, address new challenges, and ensure that the hospital's commitment to equity remained strong. Dr. Porter had become co-chair of the committee, a role that would have been unimaginable a year earlier. His transformation from the doctor who had turned away a patient to a leader in equity work had been remarkable, and his authenticity in acknowledging his mistakes had made him an effective advocate for change. "I'm often asked if I'm embarrassed by what happened," he told a group of medical students visiting the hospital. "The answer is yes, I'm embarrassed by my actions, but I'm not ashamed of the person I've become because of them." He described how the experience had changed not just his professional practice, but his personal understanding of bias and privilege. "I realized that I had been living in a bubble, assuming that my experience was universal. Learning to see beyond that bubble has made me a better doctor and a better person." The medical students peppered him with questions about how to recognize bias in their own practice and how to address it when they saw it in colleagues. Their engagement gave him hope that the next generation of healthcare providers would be better equipped to provide equitable care. Meanwhile, Denise had been invited to speak at healthcare conferences around the country, sharing the story of her experience and the changes that had followed. She always emphasized that her title had given her a platform that other patients didn't have, and that the real work was ensuring that all patients received the same quality of care regardless of their status or influence. "My experience was a catalyst, not a solution," she told one audience. "The solution came from the hard work of acknowledging problems, listening to community voices, and committing to ongoing change." She often shared statistics showing that health disparities remained a significant problem in American healthcare, affecting not just individual patients but entire communities. The work at Mercy Hill was important, but it was part of a much larger challenge that required sustained effort across the healthcare system. The hospital's community partnerships had expanded significantly. They were now working with local faith communities to provide health education, partnering with schools to address childhood obesity, and collaborating with social service agencies to address the social determinants of health that contributed to disparities. One particularly successful partnership was with a local community center that served primarily Spanish-speaking residents. The hospital provided regular health screenings at the center, offered education programs in Spanish, and established a direct referral system for patients who needed more comprehensive care. "Healthcare doesn't just happen in hospitals," Dr. Santos explained during a community meeting. "It happens in communities, in schools, in workplaces, and in homes. If we want to address health disparities, we need to be present in all of those spaces." The partnership had identified and addressed several serious health issues in the community, including undiagnosed diabetes and hypertension. More importantly, it had built trust between the hospital and a population that had historically been underserved. The hospital had also established a scholarship program for students from underserved communities who wanted to pursue careers in healthcare. The program provided financial support, mentorship, and guaranteed job opportunities for graduates who committed to working in community health settings. "We realized that one way to address bias in healthcare is to ensure that our workforce reflects the diversity of our community," Denise explained. "When patients see healthcare providers who look like them, who share their experiences, it changes the dynamic of care. The first scholarship recipients were now in their second year of nursing school, with several more starting medical school in the fall. The program had attracted national attention as a model for addressing healthcare workforce diversity. As the one-year anniversary of the incident approached, the hospital planned a community celebration to mark the progress that had been made. The event would include patient testimonials, recognition of staff who had led change efforts, and commitments for continued improvement. "We're not celebrating because we've solved all our problems," Denise told the planning committee. "We're celebrating because we've learned how to do better, and we're committed to continuing that work." The celebration would also include the release of a comprehensive report detailing the hospital's transformation, including specific interventions, outcomes, and lessons learned. The report would be shared with other healthcare institutions, policymakers, and community organizations working to address healthcare equity. But perhaps the most important aspect of the celebration would be the renewal of the hospital's commitment to equity and inclusion. The event would include a formal pledge signed by board members, senior leadership, and department heads, committing to ongoing efforts to provide equitable care to all patients. "Change isn't a destination," Denise reflected during a final planning meeting. "It's a journey, and we're committed to staying on that journey, no matter how long it takes." The story of Mercy Hill Medical Center had become more than just a tale of one hospital's transformation. It had become a symbol of what was possible when institutions were willing to confront their shortcomings, listen to their communities, and commit to meaningful change. As hospitals across the country faced their own reckonings with bias and inequity, the example of Mercy Hill offered both hope and a roadmap for transformation. The work was difficult, but it was essential, and it was possible. The ripple effects of that one morning's confrontation continued to spread, touching lives and changing systems far beyond the walls of a single hospital. And in the end, that was exactly what Denise Taylor had hoped for when she made the decision to speak up instead of staying silent. 5 years after the incident that changed everything, Mercy Hill Medical Center had become a model for healthcare equity across the nation. The hospital regularly hosted delegations from other institutions, published research on bias reduction in healthcare, and maintained its commitment to continuous improvement. Dr. Porter had been promoted to Chief of Quality and Equity, a position that would have been unimaginable before his transformation. He often spoke at conferences about the importance of personal accountability in addressing systemic bias, and his story had become a powerful example of how individuals could change. The hospital's patient satisfaction scores consistently ranked among the highest in the region, with particularly strong ratings from patients who had historically been underserved. More importantly, health outcomes had improved across all demographic groups, with the gaps between different populations narrowing significantly. Denise Taylor had completed her term as board president but remained active in healthcare equity work. She had established a foundation that supported similar transformation efforts at hospitals around the country, and she continued to speak publicly about the importance of patient dignity and equitable care. The community forums had become a permanent fixture, with quarterly meetings that drew hundreds of participants. The hospital had also established a patient advisory council with representatives from different communities, ensuring that patient voices remained central to all decision-making. The scholarship program had graduated its first class of nurses and medical students, with several now working at Mercy Hill and others serving in community health settings. The program had inspired similar initiatives at other institutions, contributing to a gradual but important shift in healthcare workforce diversity. But perhaps the most significant change was in the culture of the hospital itself. New employees went through comprehensive orientation programs that emphasized equity and inclusion. Regular training sessions kept these issues at the forefront of everyone's mind, and the reporting system continued to generate feedback that drove continuous improvement. The work never ends, Denise reflected during a recent interview. Every day brings new challenges, new opportunities to do better. But that's exactly as it should be. The moment we think we've solved these problems is the moment we start sliding backward. She paused, looking out the window at the bustling hospital campus. What happened to me that morning was painful, but it was also necessary. It forced us to confront truths we had been avoiding and to commit to changes we should have made years earlier. The story of Mercy Hill Medical Center had become a testament to the power of confronting difficult truths, the importance of listening to community voices, and the possibility of transformation when institutions are willing to do the hard work of change. And in exam rooms and waiting areas, at nurses' stations, and in administrative offices, the legacy of that confrontation continued to influence every interaction, every decision, and every moment of care. The ripple effects would continue for generations, touching lives in ways that could never be fully measured, but would always be profoundly important. In the end, that was exactly what healthcare should be. A place where every person, regardless of their background or circumstances, could expect to be treated with dignity, respect, and the highest quality of care. It had taken a crisis to reveal how far Mercy Hill had fallen short of that ideal, but it had also taken courage, commitment, and community to transform that crisis into lasting change. The work continued, and it always would. But now it was work guided by the knowledge that every patient deserved better, and that better was always possible for those willing to pursue it.